I believe, and I think all of us at the National Health Council, not just staff, the board, the members of the council, sincerely believe it's only when we do bring all the stakeholders together, listen to each other respectfully, and work together on these very complex issues that we can come up with really pragmatic, practical solutions that we can then enact. To put in context what we've heard this morning and lead us in some discussion about where the patient advocacy community specifically goes from here, I'd like to introduce Marc Boutin. So Marc, if you come on up. Marc is the Executive Vice President and Chief Operating Officer for the National Health Council. And I'm also very pleased to point out that he is the new board member for the International Alliance of Patients Organizations, and we were just really proud of that. So Marc, it's all yours.
Thank you, Myrl. As I begin, it occurs to me we've not done something that I think we all should have done, and that is to congratulate ourselves and celebrate the decision we just got. So if everybody would give yourselves a round of applause. I know everybody in this room worked hard to get different provisions into the ACA, and there was great success. I know the National Health Council felt very good about a lot of the provisions that were put in, many of them using our own language. And many of us advocated for a Supreme Court decision that would uphold this law. It allows us to move forward, but I'll tell you, the uncertainty of the last 6 months has really created some energy that has made it hard for organizations to engage at the federal level, but also to engage at the state level. I'm going to talk a little bit about what we plan to do as the National Health Council with our member patient advocacy organizations moving forward. And I'm also going to talk about some of the things we need to focus on at the state level. But before I do that, I want to remind ourselves that we came together and we looked at the different issues in health reform. We looked at what the Supreme Court could do. We planned our scenarios and we looked at what were the different options. But I think we all have to pat ourselves on the back. When you look at the Anti-Injunction Act, we predicted that that would not be applicable. And the decision essentially said it was not applicable. When we looked at the individual mandate, this was the point of contention that the media whipped up and really got everybody excited and got everybody thinking that the whole thing was going to go down. We said no, we expected a 6-3 decision, and in the end we got a 5-4 decision. We also said severability would not be important with respect to the individual mandate because it would be upheld. And again, that was the case. Medicaid expansion, we said, would be upheld by a 6-3 decision. It was upheld by a 5-4 decision. There was a caveat to that that allows states to opt out, and I'm going to come back to that in a moment. But the reality is we looked at this, we did a very thorough analysis, and we came up with the right result, and so did the Supreme Court. And that allows us to continue our work moving forward. So with the National Health Council, we're going to be focused on 3 specific issues. And these are not a surprise to anyone. These are the same issues we've been focused in on all along. And that is defining the essential health benefits, looking at issues around comparative effectiveness research, and delivery design reforms. So I'm going to take each one in turn very quickly and explain what we need to do. With essential health benefits, we all know there have been bulletins put out. We've seen a shifting of the responsibility for defining the essential health benefits to the states, where the states actually get the opportunity to pick their framework for the essential health benefit. What we have not seen, and this is critically important, and what the National Health Council has been working on for a long time, is how are we going to address the protections? How are we going to deal with medical necessity? How are we going to deal with anti-discrimination provisions? And what is going to be the oversight mechanisms? Those have been left blank. HHS has not provided us any detail on how those are going to be addressed, and we continue our work with SOCIO and ASPE and HHS to push them to address these issues. These are fundamental issues that could be addressed at the national level to have a floor, a standard on medical necessity, anti-discrimination, protections, and oversight. We have not yet been told how the Secretary will deal with these. We do know from our conversations that they will be dealt with. What we don't know is how. We need to continue our pressure on HHS to get them done and get them done in a way that is meaningful. Now I want to say that there's opportunity for optimism here. And one of the more recent announcements from HHS It addressed the actuarial value, and it did it in a way that leveled the playing field across the country. That's an indication that the Secretary is going to give a great deal of flexibility to the states, but is also going to retain some autonomy to ensure that people get the benefits in a meaningful way. We have an opportunity to have a standard medical necessity process. We have an opportunity to deal with protections, and we have an opportunity to ensure that the states provide effective oversight, and if they don't, the federal government does. Let's keep the pressure on HHS to do that. Now, there's been some discussion about when the final regs will come out. They'll be posted for comment. We'll have an opportunity to address them, but we also have the opportunity now to continue our united front saying that these have to be addressed. Some conversations would say that the draft regulations will be out this month. It's hard to tell. It's clearly been a calculation as to when to put those regulations out, and I'm smiling because Kelly over here has been predicting July. I'm not so sure they're going to come out in July. They may come out as far into the year as to be after the election. It's very hard to tell when those are going to come out. It's clear it's going to be a political calculus as to when those go out, but we have to keep up the pressure to address these components to make sure essential health benefits work for all people with chronic disease and disability. Comparative effectiveness research. One of the things that we've not focused on today are all the things that stay because health reform was not struck down. Biosimilars is going to continue to move forward at the FDA. SHIP does not now have to be reauthorized. It was reauthorized as part of ACA. You've got issues of comparative effectiveness research in PCORI being created. They're going to continue. We have been engaging PCORI and senior staff there, as well as the board members, to really address process transparency. This is a critical issue for people with chronic conditions. This is an entity that will be well-funded, that will be distributing resources to conduct comparative effectiveness research, that will be used to make coverage determinations. It will be used by patients and providers to make medical decisions that could impact their lives dramatically. And we have to figure out a process for engagement. And it requires a delineation of how that process is going to work. What are the points of engagement? Who are you asking to engage? Patients, consumers, their organizations that represent them. You have to clarify the expectation. What does that engagement mean? When will that engagement happen? We need to be able to plan in advance for that engagement. And we need to have the right modalities for engagement. Is it going to be surveys, in-person meetings? What kind of engagement tools are going to be used? We're working with PCORI to identify these, map it out, so that we all in the patient advocacy community know exactly how to engage and when to engage. Perhaps more importantly, we're helping to identify what are those points of engagement. You can look all the way from governance to the translation and dissemination of the information. We're going to the granular level of helping to identify who do you engage. Do you want an actual patient to engage? Do you want a patient advocacy organization to participate? When would you need both? When would you prefer to have one or the other? A patient comes to the table with their condition in mind, and they have a very clear perspective. And that could be very helpful when you're trying to select the outcomes or comparison factors. But if you're starting to look at how do you prioritize the research, that's probably a more holistic view where you want organizations participating as well as patients. When it comes to the dissemination, that's probably an organizational issue, not a patient issue. We have to think through the points of engagement. Who do you engage? How do you engage? Create this process in a way that works for people with chronic conditions so that we can maximize the benefits of comparative effectiveness research. We've got to look at delivery reform, and we talked a little bit about that. You heard points made from the panel on this. Incredibly important. We have some activity in ACA. We certainly have the accountable care organizations as part of the legislation. We have funds for the Innovation Center at CMS that is looking to drive how do we develop systems that will work for people with chronic conditions. We've got to take every opportunity to drive innovation. We've got to make sure that this is focused on the patient. And I borrow here from a definition from the International Alliance of Patient Organizations that took upon itself to develop a definition of patient-centeredness. And for the key components, you have to have meaningful access and support. Hopefully now that ACA is standing, and hopefully as most states will implement the Medicaid expansions, we will have meaningful access built in. You have to have choice and empowerment. Critically important that people be given the opportunity to make decisions that impact their health, their lives, in a way that is meaningful. They've got to have the information to make that determination. And clearly the work that will come from PCORI, BARC, and NIH will help inform those decisions. We've got to make sure it really focuses in on the critical questions that they want answered. But perhaps most important is respect. Respect for what the patient actually wants to accomplish in their lives. And I know Myrl often talks about our father who was a family doc. And as a family doctor, they come into your home, they get to know you, they understand you, they actually ask you what it is you're trying to accomplish. You may not be trying to accomplish the absolute best health outcomes. You may not be trying to accomplish living as long as you possibly can. You may be focused more on quality. You may want to work an extra 5 years before you retire. You might want to see your daughter get married. Those are the sorts of things that are important to people with chronic conditions. They're often not just about health. They're about the social issues that surround them and their families. And if you don't take the time to ask, to truly respect what the patient needs, you don't get to patient-focused care. You don't develop systems that really help the patient. And many of you are familiar with this slide where we really put the patient, the family caregiver, their provider team at the center. And we say you have to provide the best evidence at the point of care in a meaningful way, and that requires HIT and electronic health records and providing information on a handheld at the point of care, but it has to be based on the personal predicaments and rights and preferences of the patient. And that requires some sort of assessment. It actually requires you to ask what is important to you. What are you trying to accomplish? If we could solve that fundamental issue that we had with family doctors of years ago, we would truly start to get much closer to patient-focused care. All of this has to be in a new system that reimburses for this kind of care coordination. The accountable care organizations are a step in the right direction. But you heard from the representative from AHIP, that's only one model. We've got to incentivize many models that truly provide for this care coordination and truly incentivize this. And it has to be done in a system that addresses the out-of-pocket costs that people face. How many of us have looked at the issue of rising costs when you look at tiers for prescription drugs, and you look at the cost sharing that is happening in that area that's making it almost impossible for people to take the medicine that is the best care for them to help them accomplish what they're trying to do in their life. We've got to look at empowering people to do what is best for them in the healthcare system and put it into that context. In terms of state implementation, you've already heard the different issues that are in play. We've got to help identify the state benchmark. You know, a lot of states were sitting on the sideline, but at this point in time, every state's going to start to look at what essential health benefit are they going to pick? What is going to be the benchmark? And for those of you that are working at the state level or have affiliates that are, you've got to start assessing those benchmarks at the state level, identify which is the best for people with your condition, people with complex chronic conditions and disabilities, and you've got to put pressure on the state to pick the best benchmark. I've said this many times, some of the benchmarks are really, really good. Some of them are not very good. We have an opportunity to shape this for the future. You've got to look at the state exchanges. Many will defer to the federal government, but a lot of the states are going to be looking at how do they develop their exchanges. You've got to make sure that they are patient-centered, that they can actually work for people with chronic conditions, and to look at the navigation programs to make sure that they're partnering with the nonprofits in your community to help people get to the right plan. For those of you that were at our last Essential Health Benefit briefing, we talked about the implications of cost, the implications of coverage, and the fact that people are going to have to pick the right plan for them. That's going to require some effective navigation, and you're going to want to look at that. Lastly, Medicaid expansion. For those of you that have affiliates working in states that are at least saying at this point in time that they're not going to expand, you've got to put pressure on those states. This is a winnable issue. In fact, this is an absolute no-brainer. Right now, there's a lot of political rhetoric, and when you look at the governors who have said they don't want to participate, they're the governors that are following a certain candidate around. There's an election coming up in November. No state has to pick or decide if they're going to expand Medicaid before the November election. You have an opportunity to explain to people that for the first couple of years, this is 100% reimbursement. At the end of the time when it declines, it's 10% and you get 90% back. For millions of dollars, you're going to get, in some cases, billions, potentially even tens of billions of dollars. I ask anybody to give me an example where you can invest that amount of money and get that kind of return. You simply cannot do it. Nowhere. Nobody is going to refuse this in their right mind, and the patient community, partnering with the other stakeholders, have the opportunity to make sure that every state expands their Medicaid population. I want to remind us as well where we are in the process. Now, many of you work in government relations, so you understand this slide that when you really want to get something done, you start with policy formulation, you develop legislation, and you go into implementation. For many people, it feels like their entire career has been spent on this bill. And we've been working on it for a long time. The concept of this legislation started decades ago. The actual legislative drafting started about 5 years ago. It became law 2 years ago. We're only 2 years into implementation, and guess what? We have 2 years before it really becomes operational. We're still at the very beginning of the implementation phase. We have not yet made it into the official modification phase, and yet we have people talking about repeal and replace. Let's get rid of provisions we don't like. Let's add things that we'd like to see. We're already into the modification, and we haven't implemented it yet. That's going to continue, and once we've implemented, we're going to go back into policy formulation and look at what we liked and what we didn't like, and we're going to develop new legislation, and then we're going to implement this. The reason I point that out, folks, is this is not going away. Many of us will spend the rest of our careers working on this. And it's something that we have to get our arms around, because I think a lot of people had hoped that once the Supreme Court came up, the uncertainty would be gone. One way or another, we'd have certainty. And the reality is we're living in a state of high uncertainty. And that uncertainty is going to continue not just for the foreseeable future, but probably at least for the next decade. We have elections coming up. Congress is going to change. The Senate may look very different. The White House could change. Even if the White House stays the same, you can expect senior leadership within the agencies we deal with to change. We're going to deal with a budget. We're going to deal with sequestration and deficit. We're going to deal with an economy that has not been recovering at the rate anybody would like. Uncertainty is not going away. And that creates a huge opportunity for everyone in this room. You represent the organizations that are the leaders for your condition or your profession. You are the respected, trusted source. And as Colin says, in points of high uncertainty, we all want somebody to help us, to tell us what to do. We have volunteers, we have grassroots, grass tops, even staff that are looking to the people in this room to help identify what do we need to do. We know what we need to do on the federal level, we know what we need to do on the state level. We've got to lead, we've got to provide that direction, and we can have as much impact as we did on the legislation, on the implementation. And this is going to have huge repercussions for all people with chronic disease and disabilities. We're at a point of uncertainty. It's going to be a long haul, but we have a huge opportunity in front of us. And while you want to stay excited, I suggest that we get a little bit about that. I'm happy to take questions if anyone has any.
Marc, Richard Myrl, representing the National Alopecia Areata Foundation. Clearly, the law is bifurcated between federal role
The challenge with the state level, as you saw, is that each state has different opportunities in terms of what they're doing. So I would again encourage you to look at the website that was put out. That actually really focuses you in on the key issues. The essential health benefits, navigators, looking at the opportunity to engage with the state exchanges. That allows you to look at exactly where the opportunities are in the state, and then to encourage them to put their resources there. That is the key issue that every group that has an affiliate should be looking at. How do I put our firepower behind those three issues at the state level? We can't do it all, and we've got to be focused. Those are the three most important issues at the state level, and we're fortunate that we have an organization that is really collecting that data so that you can have that level of focus within each state. The last thing I would say about that is that there are coalitions within the states, and many of our organizations are participating in that. I know American Heart, Cancer, Diabetes, MS, etc. have formed coalitions at the state level. There's an opportunity to participate. Not every group is going to have a voice in the state exchanges per se with the decision-making of the governments, but every organization can participate as part of a coalition and have their voice heard at the state level. Thank you.
Hi again, Charlotte Collins from the Asthma and Allergy Foundation of America. Thank you, Marc, for your assessment. I guess my short question, I see there are someone behind me. My short question is regarding the Putting Patients First campaign, which I think was a really effective way of bringing all of us, as well as other volunteers, together on a national level to help get the ACA over the hump and enacted in the first place. And I think we were successful with that. However, since it's been enacted, a couple of huge hiccups have happened. One is, in terms of covering everyone, which is our first principle, that has been upended by the Supreme Court's decision to allow the states to have at it with respect to Medicaid expansion. Already you hear, I think we here in Washington are really naive and blindly assuming that states are going to act in their own best economic interests. I've come from a long background that included a lot of advocacy for Medicaid expansion in the southern state. And I will tell you that it doesn't have to do with economics pretty much at all. And it's very difficult, I guess, sitting here inside the Beltway to understand why a governor like Bobby Jindal of Louisiana would make a statement saying that there's no way that we're going to do a Medicaid expansion when a Medicaid expansion would take care of 60% of the uninsured in the state of Louisiana. If you could not understand Dixiecrats, then you won't be able to understand that kind of rationale. So I guess my question is, beyond the very effective implementation strategy that the Health Council has adopted and plan to move forward on, is there a plan to keep putting patients first in place so that we can look at it pretty much as a political campaign to help support efforts of members and other volunteers in the states as they try to get realization for covering everyone?
Great question, and we absolutely will continue our efforts under the tagline of Putting Patients First to keep up the pressure, in particular on what's happening at the federal level, but also trying to help our members deal effectively at the state level. Obviously our focus is on the federal level, but I will say that I think you're absolutely correct. It is a political calculation as to whether or not a state will expand Medicaid, and that is a huge risk. But the messages and the advocacy are winnable in every state on that. And I truly believe that. When you're talking about 2 years of no cost, and eventually the cost only being 10%, when you look at previous practice here, eventually the states will take that money. And I think with advocacy with virtually all the stakeholders, we can put the kind of pressure that needs to happen. Now we've got the November elections, and that creates a challenge because there's going to be a lot of hyperbole around that. But as we move beyond that, we have the opportunity to pull every state, so I truly believe that. I will say as well that I'll kind of quote a former governor of Alaska who said she would not take the money to build a bridge to nowhere. She took the money to build a bridge to somewhere. Everybody takes the money, And I think we can put the pressure on to make sure that this money is brought in so that people get the expansion in coverage that they need.
Suzanne Williams, National Family Caregivers Association. Good presentation, Mark. I was interested in the definition for patient-centeredness and the inclusion of the term respect, which I believe is critically important, especially for family caregivers who get absolutely none. And as you probably know, we are working on an initiative to have family caregiver data included in medical records. And I would like to use this platform to encourage people to get in touch with me if they are indeed interested in that initiative. And with the assessments to find out about what people really want, I think it's critical to talk about not just the patient assessment, but also the primary caregiver assessment.
That's a really good point, and Suzanne has been a leader not only in this area, but in helping not only the National Health Council, but many of our members reshape not only our thinking, but our language, where we say people with chronic conditions and their family caregivers. So absolutely couldn't agree more, and I would encourage people to take a look at their website on some of their activities. It has huge implications for all people with chronic conditions. And I see that there are no other questions, and I do not want to hold you any longer. I thank you for your time, and most importantly, I thank you for all